to Unboxing Performance. I am your host, Vito, accompanied always with my fellow co-host, Vince.
What's up, y'all?
Today is episode 5, so we just finished up doing our anatomy and biomechanics of the knee. Now we're going to jump into some pathologies. Now, we study more. There's a ton out there, but we're just going to highlight 4 that we think are ones that we studied and have pretty good research on, and that we think are valuable to those working with an athletic population, especially with younger athletes. So we're going to cover osteochondritis dissecans, patellofemoral pain syndrome, patellar tendinopathy, and then we'll talk a little bit about ligament injuries, but we're mostly going to focus on the ACL and then ACL reconstructions. So, Vince, you got any other notes, or should we just jump into it?
No, I think that just about covers it.
Cool.
Let's get it.
All right, so on the osteochondritis dissecans, I have my notes here, so that's why I'm looking off screen. Don't worry about it. Is a alteration of subchondral bone, which is very interesting. So we're going to look mostly at the femoral condyles here, but it's some type of injury has occurred. It can be a traumatic injury, it could be microtraumatic, or it could be related to genetic defects. So if the presence of the ACAN gene or if OCD has occurred in family history, it's something to be considering. For a traumatic injury, it could be a bone bruise, like an aggressive impact that caused some sort of disruption to the bone below the articular cartilage, or if you have a microtraumatic injury. Our notes from class from Mark was that it could be like repetitive squatting, like a catcher in baseball, sitting in that squat position for a very long time, causing abnormal stress. And some of the symptoms that we'll see is there's going to be pain with weight bearing. Swelling can happen if there is a disruption or fragment that is broken off of that cartilage that's free floating in the knee. We can see locking. So the knee is just not able to participate in its full range of motion. So we'll see range of motion impairments. Clinically diagnosed, we didn't get a lot. And you can use like rule in, rule out measures, so you can rule out other things. The main test that we have is that they may have pain with palpation on those femoral condyles in different knee flex positions. So you're just going along trying to feel that articular cartilage, just seeing if that's what's causing their pain. So it comes down to palpation. There are surgical options, so an orthopedic surgeon might go get it imaged, and then you can see this changes there at the end of the bone. And yeah, it's very interesting. It happens primarily, the etiology is going to be in teenagers, 4 times more likely to happen in boys. Why? Don't really know. It's an interesting disease. One of the things that we can do, so if it's a stable fragment, so if whatever that is it's stable, it's not moving, it's not free floating, then conservative therapy is great. PT can help. We do protective weight bearing during tissue healing. We can modify activity, usually about 3 months, same following tissue healing timelines. And then it becomes impairment driven. If there's strength deficits, if there's range of motion deficits, if there coordination deficits, we can treat them based on just how they present. But it is very interesting and also not super clear. Now, if there is an unstable or a free floating fragment, one of those that's lost in the joint, it's actually impairing motion at this point. There are different types of surgical procedures that can be done, and then we're involved in the afterside. So some of the surgical procedures we see is they microfracture the bone. If the bone is involved, then it can heal, and then hopefully see some cartilaginous regrowth. If it's just cartilage and there's no bone damage underneath, articular cartilage isn't just going to regrow. So they'll do some microfracturing. There's also osteochondral grafting or mosaicplasty. So if there's a lot of articular cartilage missing, what they can do is they can surgically implant different pieces, and hopefully we get some regrowth there. And then there's autologous cartilage implantation. I think that's where they send it off to some of those Boston tissue regrowth sites, and then it takes however long it takes to get those tissues regrown, but then those can be surgically inserted. Yeah, so an interesting one. Vince, you want to talk about the next one?
Yeah. So patellar tendinopathy, kind of going into more of the tendinous pathos. Uh, Very often seen in a lot of athletes due to change in training protocols if they're just deciding to go a little harder. A lot of times it happens in the transfer from high school to college. Those commonly in runners. So we see those runners now going into college. Training regimens are a little more intense. They're running a lot more often. start to experience pain right at that patellar, patellar tendon, typically during your history, they're going to know and they're going to show you, point right to it, that they're experiencing pain right here. It hurts when they move, and typically during palpation, if you compress it a little bit, it should relieve, and that's going to be one of the special tests, palpation. There also is indicative with a single leg decline squat. I don't know if you remember going over this during class, but basically you have the patient on an angled surface into a plantar flexion state. They're going to do a small single leg squat, doesn't have to be full depth, just about a quarter. And they'll typically point like, yeah, pain's right there. And that's going to be your surefire sign almost that they have some patellar tendon pain. It's typically more intense at the interpatellar pole. That's going to be right underneath or at the apex of the kneecap. If you remember from the anatomy episode when we talked about the anatomical sites of the patella. One other test, I kind of talked about it, is going to be the Royal London Hospital test, which is going to be the palpation of the tendon and reduce pain with compression over that in motion.
So that's a
And
dynamic test.
that's it is, and it can be crossed over if you have ever seen people with kind of splints or braces underneath, kind of just wrapping around. That's essentially what they're trying to aid in is that reduced pain just by compressing the patellar tendon. But it's a short-term thing. We want to intervene on that and help reduce it in the long run. Uh, some big interventions have to do with resistance training. A lot of eccentric work with the quadriceps. So I don't know if you've ever heard of a Spanish squat or a sissy squat. Essentially, we can throw up a picture of that, and I can send that to you, Vito. It's essentially resistance band wrapped around a pole. You're going to wrap it right behind your knees so that it's wrapping posterior. And all you're going to do is about a half squat, doesn't have to be full depth. And as you come up, you're going to be resisting the pull from the band and forcing your knees back and really trying to get a good contraction of your quadriceps in that and squeezing pretty good. The other resistance training you can do is just slow and heavy movements. So leg press is good because it's going to take away from spinal loading, so you won't have to worry about that, and you can actually just focus on that contractile force and really load up the legs. And then also isometrics. So doing just like I was going to say Bulgarian, but doing a goblet squat just in pause, do a 3 point pause, which is going to be pause at depth, pause at half, and pause at quarter, and holding those for about 5 seconds is really going to be a good exercise to try to integrate into your training. And then outside of resistance training, quad and hamstring stretches are also really good. If you're not a stretcher, which I feel like is a very common thing for a lot of college athletes that we tend to neglect, stretching can really help. If that quad is really pulling on that tendon, you're going to have a lot of irritation during training. So it's important to make sure that we have strength as well as length, because both of those are going to be really important in activity. And then not a lot of actual research, but a lot of anecdotal evidence that foot orthotics are really important for this uh, type of pathology. Uh, if you don't know, our body works in a type of chain, so everything's systemic in a way. So not wearing the right shoe wear during your training can really affect pain up the chain, and that's oftentimes why foot orthotics can be beneficial if you're not training in the right kind of shoes. You change the shoe and you notice a benefit or decrease in pain, and that's another thing you can do if the resistance training is not working. It's more of a quick fix. I like to think of it as it's going to fix in the meantime while we intervene to make sure you can actually do the exercises during that time. And then, quick little tidbit, I actually, when I really got into lifting during junior college, started to experience a lot of this pain. and wasn't able to squat as heavy as I wanted. And I started looking into it myself before we even covered the class. And eccentrics was the biggest thing that I found to help myself personally. So I don't know if you remember early on before we were really friends, Vito, if you saw me at Vasa, just always doing banded sissy
You still
squats
doing
and just
today?
really working on that. I still do them, and it's been great. Personally, I haven't had any knee pain in a few months now, actually. I almost forgot I had it until reading these notes, and I was like, "Oh yeah, this was something I struggled."
So did it?
Okay, it says I'm recording again.
Okay, when did it say it stopped recording?
Um, I have no idea. It was at the end of everything basically from patellar
Okay.
tendinopathy though. So all the important stuff is in there.
All right. Well, we'll figure it out, make it work. If it's recording, let's keep going. There was a question I was going to ask you about setting up those interventions based on acuity. So if you had a high acuity patient, where would you start with your resistance training between those three
Um,
exercises?
yeah, so obviously you're not going to go extremely heavy and you're also not going to load them up. You're going to go more for pain management. So the problem with this kind of pathology is that it's onset by activity. So I would move into more of the stretching aspects, see if there's any impairments in there, check their muscle length, and intervene that way. Check for systemic issues if they're having like ankle pain. Approach that first and see if that actually helps manage their pain a little better. We want them to be a little lower if you give them like a visual analog scale of pain. So ideally, start working with them when they get to about like, I feel like 5 would be my comfort zone. If they're at like a 5 out of 10 pain, granted, if they came in at like an 8 out of 10, you're able to reduce that by 3 just by approaching the other areas, which is great. So I would say at that point it's good, but also provide some education that this is something that it may cause a little bit more pain during, but should not cause pain after, and eventually will relieve it. So if they experience a little more than usual during the exercise, not to be too worried and approach it that way.
So patient education, use sins, severity, irritability, nature stage.
Hmm.
Um, my thinking is I'd probably go iso, like obviously would address other impairments from on resistance training. I think I'm going to jump into isometrics before the other two just to see their response to it,
Hmm.
and then move as quickly as I can into eccentrics based on patient tolerance. I agree. Heavy and slow, maybe not the first thing.
Hmm.
Eccentrics has better research anyway. It's the same concept, but I would say if we're doing quadricep eccentric targeted, it's going to be more effectual at that point. Um, and then once we can get that pain down, retraining um, whatever activities were causing it. So doing a movement analysis. But yeah, I'm in agreement. Let's address anything we can. Let's do some patient education. Um, Set expectations that you're going to have pain, but it doesn't mean we're making the tissue more injured. Right? We're not damaging anything. We're fixing it.
Exactly.
Okay. Similar, jumping into patellofemoral pain syndrome. So this would be pain or dysfunction associated with patella or patellofemoral joint. Um, Often you're going to have general complaints of anterior knee pain. There may be some crepitus with movement of the patellofemoral joint. So if you're doing some palpation or some joint accessory motion testing, and then your symptoms are going to be seen increased with stairs. So if you're ascending or descending, going in squats or prolonged sitting. That's called the theater sign. And what's really cool is it's another pathology that has a clinical practice guideline. And so how it breaks it down is there's four classifications, and then we have our interventions that go directly into each of those classifications. And a patient should fit into one. It doesn't mean that they don't have um, problems in the other, but you want to address the one that's causing and then address other impairments. And that'll make more sense as we go. But so the first one that we look at is, and this is if you've ruled out the other three, it's likely overuse or overload without other impairments. And one of the ways we test that is the eccentric step down test, as long as we're also ruling out the other three. Then we have our with muscle performance deficits. So then we're looking at strength testing. One of the things we can do is we can do the hip sit, we can do isometrics for the hip muscles. We're looking at the adductors, the external rotators, the extensors, anything that affects up the chain at the knee level. And then, of course, we'll look at the knee level itself with our knee extensor complex and our knee flexor complexes. Um, so
Oh,
that's looking at,
let me stop you real quick.
okay.
Um, so that single leg step down test, also, I think it's important for listeners to know. Same test can go for patellar tendinopathy, and it's important to take their history into consideration because PFPS is going to be more painful at rest, while patellar tendinopathy is going to be more painful during activity. So that's where we can distinguish if we decide to use that test, and those are our two differential diagnoses. That patellofemoral pain is going to be uh, non-emotion or non-active, patellar tendinopathy active. Just one thing I wanted to
No, no,
address
that's really
before we
good.
get too far into it.
Yeah, that's where the testing your CDM, your clinical decision making, and your rule in rule out. So if you get a positive Royal London, probably not going to be patellofemoral pain syndrome. You're likely looking at that patellar tendinopathy, or knowing where the pain is. If anterior knee pain, it's on top of the patella, not the inferior pole.
Hmm.
Might lead you towards one way or the other. So we
Exactly.
talked about overuse, we talked about muscle performance deficits, then movement coordination deficits, and this one gets to be really fun. So there's two main tests that we use that are verified through the CPG. That's going to be the dynamic valgus on lateral step down test. So you're stepping off to the side, seeing if their knee caves in, and then a frontal plane valgus during a single leg squat. So you're looking at them from that anterior position, and you're watching that knee joint as they try to lower into a single leg squat. Is that knee valgusing inward? Another thought is those are the verified ones. Those ones we can use like rule in, rule out, great. But movement analysis, especially when it comes to movement coordination deficits, is going to be really, really valuable. So think about the activities they perform regularly. They'll tell you exactly when it hurts, why it hurts, and how it's hurting, how long it's hurting. So you can look at the same movement. So if it's a running, do a running analysis. If their knees are caving in while they're running, great. Now we know that there could be a muscle performance of the adductors, or they are having a movement coordination deficit, allowing for dynamic valgus during the activity they're trying to work on, and that's what's causing that pain. So do the verified tests to rule in, rule out, and then also see what movements you need to address in your examination before you go to your interventions. And then the last classification. So it goes overuse, overload, muscle performance, movement coordination, and lastly, mobility impairments. There's two subsections here. We didn't really cover the first one as much in class as much as we did the hypomobility section, but let's start with the hypermobility of the foot. Just like you were saying with patellar tendinopathy, everything works in a chain. Um, One of the books that I've read, the Squat Bible, it's by a couple PTs. I can't remember off the top of my head. It is not in front of me, but it's a great book, and it talks about you have your mobile joints stacked around stable joints, stacked around mobile joints, and even when we cover thoracic spine, it's like the great compensator, right? It's going to do what it needs to do to help other joints. So if you have problems down the chain, the knee might be being affected by it. So hypermobility of the foot, one of the things that we can use as a test to see if this is something that might be causing it is called the navicular drop test. Um, and we're looking at the width of the foot in non-weight bearing and the width of the foot in weight bearing. And sorry, that's the other one. Um, so you can look at the width of the foot and non-weight bearing and weight bearing, and then there's also the navicular drop test. So how much does it drop when you go into that step? And it's just looking at subtalar pronation. And if you're pronating at the subtalar joint, that's going to affect the knee right above it, right? And both of those are good to excellent in determining if those are factors. If your patient has patellofemoral pain syndrome and you put a foot orthoses in there to address those foot mechanics, and it has a good to excellent chance to remove some of that pain. So
Yeah.
assessing below hypermobility of the foot may be helpful in determining how you want to treat the knee. And then, of course, we'll look at the knee itself. We're looking at hypermobility of the lateral patellar retinaculum. So using the patellar tilt test, any sort of joint accessory motion at the patella, which you're probably going to be doing anyway if you're looking at knee. And then muscle length testing. Is there a length problem that's preventing some sort of motion, whether it's full extension, full flexion, or it's really, really tight and painful at full extension and full flexion. So checking the hamstring, checking the quads, checking the IT band, checking the gastroc soleus, and then look up the chain here too. Is there restrictions at the hip that are now seeing compensations of the knee? So an internal and external rotation. Interventions. So we talked about the 4 categories. Your intervention should address whatever category you classify this patient in. So if it's going to be an overuse or overload impairment, first thing you want to do, modify activity. One of our professors, Dr. Mark Ryan King, he wrote a paper, and just similarly, it's on medial tibial stress syndrome, so it's not the same pathology, but we see it in runners. You got to be able to modify the activity to let some of the tissues that are affected relax and heal. So we'll modify the activity. It doesn't mean that they can't still exercise. We still want them exercising. We still want them moving. But how can we shift the stress level? So if they're a runner, maybe we do a walk to run program for return. So we cut back on the number of miles they're doing, have it as a walk and run progression where we slowly decrease the walking amount into the running amount. Then we up the mileage. We can think about using a bike to keep up aerobic capacity if that's less irritable for the patient while the tissue is really inflamed, or if it's not inflamed while it's acting pathologically. And then, utilizing, pools are always good for deloading, shifting, going from a cross-training perspective rather than just long-term running. And then let's get into movement coordination deficits. So gator movement retraining is kind of what I alluded to. We look at their valgus tests, and then we also want to look at what are the activities that are causing the pain. If we saw some sort of deficit in that, yay! I hope it records that last
So,
section.
yeah, so I don't know what's up with these.
I don't know. Okay, we did movement coordination. Let's get into muscle performance. Great. So muscle performance, we're looking primarily at strength. It could be a power problem. It could be an endurance problem. But let's look at the strength because that's probably what we tested in our isometric setting. Hip and glute strength, quad strengthening. Do exercises that strengthen those. We're all movement experts. We should have some sort of exercise background at this point. So if you want to train quads, you got to train extension of the knee, extension of the hip. If you want to train hips, if you're doing glutes, we're going to do hip extension movements. And then we can train anything we want in the gym, but then we got to get back onto whatever activity is causing that problem too. So I just listened to the PT Inquest podcast last night, and they were talking about rec fem injuries in soccer players. And one of the things that they really get to is when you're doing the end phase rehab. So you're through the tissue healing where there's inflammation and proliferation. You're towards the end of proliferation and remodeling. And you're thinking about prevention as they go back in. Utilize the activity was the mechanism of injury. So if they're a kicker and you're trying to retrain rec fem injuries, you got to kick the ball. So we can think about that here too. If it's patellofemoral pain and they're having some sort of muscle performance deficit that's causing an injury, train that whatever mechanism that caused it. Does that make sense? If they're bad at squatting and there's a weakness, work back to getting back to squatting because that's what the patient wants to do. So specificity of training. Does that make sense, Vince?
I can't hear you.
Can you even hear me? Oh, great. Can you hear me now? Great. Okay. I'll be back.
Ideally, he'll come back. Let's see. On a side note, one thing we don't often talk about, and I feel like there's a big school of two different schools of thought, I would say. Oh,
Back.
he's
Can you hear
back.
me now? No?
Ah,
Now you can hear me?
ah.
Great. Where'd we get to?
You talked about performance, didn't you?
Yeah. I was talking about performance. When's the last thing you heard?
Kicking. Kick
Yeah.
again.
So just training mechanism of injury. If your patient loves squatting and they're having patellofemoral pain syndrome and there's a performance deficit or movement coordination deficit, get back to the activity that was causing the problems. They have them do it correctly. Get to what the mechanism was. That's your end phase rehab and prevention strategy. And then the last section, PFP with mobility impairments. We talked about the hypermobility of the foot, so using an orthosis or taping to see if that changes pain. It could be a great intervention. And then hypermobility, how do you address things that don't move well you force them to move? So soft tissue mobilization, patellar mobilization, APPAs at the knee for FibFem or TibFem. Stretching, if it's a stretching problem with the quad and the hamstring, try to lengthen the muscle tissue. Strengthening puts a lot of stress onto those tissues too, so you could do some contract relax where you're utilizing some sort of PNF patterning to hopefully lengthen that tissue as well.
All right, cool. So let's get into some ACL. So ACL injuries, tears, one of the biggest things we hear about in sports, I feel like. Uh, Mechanism of injury is going to be, if you're thinking non-contact, it's going to be the overtranslation essentially of the knee on a planted foot anteriorly. Typically, if you have any kind of free sprain, you'll see that there's valgus force also within that plant. So as femur shifts forward, it's also going to be an inward force, so it goes medially and forward. And that we can talk about some multiplanar instability in a bit, but that is one of the things you can also see. And then also, it is possible to have this injury during deceleration on a hyperextended knee. So you try to plant, your knee locks out unintentionally, can also cause this type of injury. It's where the femur is going to be sliding and posteriorly past the stable tibia is the note you have.
That's what I was going to say. So which one moves forward? Is it the tibia or the fib or the femur?
So ACL prevents anterior translation of the femur on tibia. In reference to an open chain movement. So, do you remember? Tibia, ACL is the forward X, PCL is the backwards X. And when the femur moves this way, the ACL stops it from that motion. Why don't you check out that image we have popped up?
Okay, but what's the posterior sag sign for the PCL? What's the Lockman testing?
Am
Do
I
the
mixed
Lockman
up?
in your do the Lockman test in your head real quick. What are you moving?
That's why we're students. That's why we're students.
uh, I even wrote it for you. The
Wow.
direction, the
Was I
directions
that
with respect to the
confused?
tibia. Yeah, that's my as I do the posterior sag sign. It's like, oh, the tibia is posterior in the piece because the PCL is gone. Oh, Lockman or the anterior jor. If it goes forward, the tibia is going anterior. The anterior ACL, the anterior cruciate is damaged.
Sick.
Do you want to just redo that and cut this, or do you want to let it rip?
Oh, I thought you'd just let it rip. Let them
Let's
know
let
that
it
I
rip.
don't know let them know I don't know everything. In
It's okay.
fact, less than most. Anyways, so ACL, anterior cruciate ligament, prevents anterior motion of the tibia on the femur.
There we go.
Now. We'll throw an image up just so you can see some of the pictures of that. And then So some tests that we're gonna have that you heard Vito mention that helped me relearn it. It feels like is gonna be that Lockman's anterior drawer and posterior drawer. So I believe it was it the Lockman's that is going to be a more indicative test acutely.
Yep.
So Lockman's, uh, let's say on site of injury during a game or something, if players having some issues, you'd want to perform a Lockman's, and then the next day after, use the drawer and posterior drawer. One other test that you don't have on here is also the lever test, which
Yeah.
is also another thing you can do. That one's just simple, putting your arm underneath the patient's tibia, just just next to the knee, and you're going to push down on the femur right above the knee, and you're waiting to see if you can create a lever with their foot, turning it up and down.
Hopefully it goes
Obviously,
up.
hopefully it goes up. If it doesn't, they may have an ACL issue. Now, now there's reconstructions. We're not going to get into copers and non-copers. It's surgeries typically for a non-coper patient who is not rehabbing well through uh, just living
That
without an ACL.
or just prognostic factors. If they're young, they're an athlete,
Yeah,
they do dynamic activities. It's probably better just to redo it. Get a new one in there.
pro- probably. Uh, the rehab we have for that is we use the MOON protocol, which is the MOON stands for Multi-Center Orthopedic Outcome Network. And there's plenty of protocols out there. This is just the one that they teach us. I think the reason they like it so much is because it's a very big conglomerate of a lot of resources, and a lot of colleges and professional sports use it for their rehabs. Um, it's a 5 phase protocol, very common for this. First phase, obviously, we want to minimize pain and swelling and normalize their gait once they're into a better healing timeline. First week is usually pretty immobile, a lot of just elevation, price, protect, rest,
Hmm.
all that. And then into phase one, which is going to happen about from surgery to 2 weeks, is really what we follow, depending on the patient's swelling and uh, sin signs. So we're going to go into some full knee. We want full knee extension range of motion, and we want some quad activation. Those are the two biggest things that we're going to be striving for in that first phase, in that first 2 weeks, because if we can't get those right away, it's going to make everything down the line a lot more difficult. And then a good goal to keep out is more greater than or equal to 20 degrees of no lag in a straight leg raise. So that's going to be a good indicator of quad activation. So if they're not able to raise their leg and keep their knee above 20 degrees, then that shows you that they need to up their game, probably put some FES over that and try to strive for some more activation. And then as we move further into the phases, we'll get into some early rehab, which is going to be going into some full range of motion. So trying to get that knee past 90. And let it be known, first phase, you're not going to want to put the knee past 90 because that's going to put the ACL on too much stretch and potentially ruin the integrity of the surgery. So important to know how surgeries work and what to avoid during that time. So post 2 weeks, healing timeline should be good, and you should be good to go into some more range of motion. You could also start with some more strengthening exercises. You're going to do some low load, long durations, and then doing a lot of just like very passive range motion, can go into some active. And then phase three is more going to be strengthening and control. So working on stability during activity, stuff like that, and while maintaining range of motion. During this time, you can integrate a lot more strength. So start them squatting, get them into a leg press, hamstring curl, knee extensions, all that, all that caveated with not overdoing them, but also progressing them actively. And then once we get into our phase 4, it's going to be more advanced training. So this is at the point that you can start pushing them a little bit more. And then phase 5, we're reintegrating sport and we're returning them back. So phase 4 is going to start initiating more sports related motion. Phase 5 is going to get them completely into it. And one thing I'd like to mention, a lot of ligament injuries can occur. ACL is not the only one that can be involved. It's important to consider those. And a lot of times, this protocol can cross over a little bit just because healing timeline, what you're striving for in the knee joint, and just knowing what motions to avoid. So PCL, slightly different, but you're still going to want to integrate these phases in the same amount of time, keep that same timeline going for it. And then if we get into meniscal involvement, I don't know what you're doing, but it
Sorry.
is making a lot of noise.
Done.
All right. So meniscal involvement, if they have to get a meniscectomy, just know there are no precautions or contraindications with the meniscectomy, but meniscal repair will, and to understand the healing timeline for that kind of follows similarly, and they're just not going to progress as fast as they would with an isolated ACL injury.
And the weight bearing component is a big problem.
Yeah. Care to talk about that a little more?
Um, yeah, so articular cartilage, you just don't want to be compressing on the fiber cartilage if you use it to repair. I don't remember the exact one, but I think I've heard it's typically like 6 weeks of non-weight bearing to let that tissue heal before you compress on it again. And the immobilization aspect and the lack of quad activation aspect really makes that rehab process difficult. Now, it depends on your surgeon, it depends on the protocols. Um, yeah, meniscus just really complicates the matter. And it makes our job a little bit harder, but also makes us just as important, if not more valuable to those patients.
Yeah, exactly. And then that's going to basically cover ACL rehab. I mentioned earlier multiplanar instability. That's going to be very common in younger athletes because they're still growing and typically hypermobile for a lot of those young sports. So overall strengthening for them for multiplanar instability because having multiplanar instability can lead to damage of the ligaments, and we want to make sure we keep that all tight net. So
Or
integrating
if
some,
they have multiplanar instability because of multiple ligamentous injuries that's causing that rotary instability,
which
that
one
might
came
be,
first?
yeah.
Chick- Yeah, all right. That covers it for
Um,
me, Vito.
yeah, I just want to throw one thing out there. Obviously, we're not in clinic yet, but I was listening to the Mike Reynolds podcast from yesterday where he had Russ Payne, who's a PT out of the McGovern Medical School, and he's a director of rehab and sports medicine there. Um, and they talked about EMG biofeedback versus FES, and I obviously have no clinical experience outside of my 6 weeks. Um, but
Same.
it seems seems as though that, and it depends on who you talk to and the research you want to look at. FES is great for creating a reverse contraction. EMG biofeedback is great for reconnecting that neuromuscular connection and using something that a patient can visualize, external cueing, trying to bump the line up as high as they can, could be really, really, really valuable early on. Now, if they can't get any quad activation, maybe some reverse contraction is good. But if you want to go through the principles of recruitment, from that fast fiber all the way to the slow fiber, or slow fiber all the way to the fast fiber,
Mhm.
um, you might consider EMG biofeedback to just reestablish the neuromuscular connection.
Yeah, and actually, we used during my 6 weeks of clinic experience, we had one ACL rehab on a child, and we actually used a lot of EMG on him, and the biofeedback, it was just on an iPad that we connected some pro or pads to electrodes, and the game was a racing game, and
Wait,
it
what's the name of this?
they
Is it M
never get
Trigger?
they
Because
never told me.
that's okay. Never mind.
I don't know if it's M Trigger because they had a lot of options for games.
Okay.
They had like a Flappy Bird kind of game in
Oh,
there,
okay.
had
But
like a
the
dirt bike game.
program I think was called M Trigger, not necessarily games. But yeah,
Oh, so yeah, he used a racing game, and in order to turn, he would have to activate a squad, and
that's cool.
he loved it. We started every day with it.
All right, let's turn it on. Turn it on. Win the race. Turn the corners. That's cool.
But yeah, that's my one morsel of
Your
experience with that.
anecdote.
Yeah.
Cool. Alrighty. Well, let's call it, huh?
All right. You got some editing to do with these.
Yeah, let's see if it worked at all. All right,
Cool.
later.
Later.